If you look at the data that's published very recently by Iris Papageorgiou in the White Journal, he shows that if you look at these markers, the primary markers, and if you want to extend by looking at the other markers, if you are an enthusiastic practitioner, that you can detect 80% of babies with spina bifida in the first semester. I think increasingly in the new world that we live in, recognizing the value of prenatal surgery and operating on babies with spina bifida before they are born, I think it's going to become increasingly important that we pick these up in the first semester of pregnancy. In Australia, we counsel patients and offer them prenatal surgery. We have one centre that does this, and in the States and in South America, multiple centres. And the evidence is convincing the benefit of outcomes, improved outcomes in babies where an antenatal diagnosis of spina bifida is made. So the emphasis is strong for making this diagnosis early, so you can work patients up. When you look at spina bifida, it's not one condition. In fact, there are many different types of spina bifida. The most common one that you will see is where you see a bubble at the base of the spine with the neural elements projecting into it. These represent about 80% of babies with spina bifida. The other remaining 20% is where there's an ulcer in the skin. There's no bubble or closed spina bifida. This, if you look at the spine, you will pick up 30% of babies with the bubble in the spine by looking directly at the spine, or the head signs will point you towards there. It's a very straightforward diagnosis once you realize the baby has spina bifida. However, when the baby has myeloceles, they're extremely challenging. And there are some very important rules that you don't do any harm to any patient that you should follow. If you look back in time and you say, Simon, spina bifida, why is it so difficult in the first semester? Second semester, such an easy diagnosis. You see a lemon-shaped cerebellum, a banana-shaped cerebellum, and you see a lemon-shaped head. And you can make the diagnosis based on the shape of the cerebellum and the shape of the head. This is a baby at 20 weeks with spina bifida. It's a very straightforward diagnosis. Here's the lemon-shaped, here's the banana-shaped cerebellum, and here's the spina bifida. I think everybody in this room will make that diagnosis tomorrow morning without any difficulty. But what about 20 weeks? Why don't we just look at the cerebellum? 14 weeks. Why don't we just look at the cerebellum at 14 weeks or look at the shape of the head? Because it's of no value. In fact, if you actually look at it, the value doesn't rely in the posterior cranial fossa, where most information, the most helpful sign is actually in the midbrain, in the brainstem. You remember when I showed you the very first picture today, I said you take 4 sections of the baby's brain. You will remember at section number 3, when you look at the head and you draw a picture of the aqueduct of Sylvius, which is a box of fluid, you will see the position of the aqueduct of Sylvius is at the junction between the anterior 2/3 and the posterior 2/3 of the fetal head. But in spina bifida, what happens is the BPD, when you go to measure the BPD, is the cerebral peduncles and the thalmi are pushed back and they are juxtaposed to occipital bone. If you do 100 BPD measurements, the next one that looks like this will strike you without needing to measure anything. But it's very important when you do this measurement, there should be no choroids in view, because otherwise it's a complete section and you make it look as though the BPD is right beside the occiput. You're taking a complete section. So that's the first thing. The second thing is, you may find that the distance between the brainstem and the occipital bone on sagittal imaging is reduced. It's the same thing what you're looking at in axial. The brainstem is pushed to the occipital bone. And that they are the 2 stronger primary signs, what I call primary signs. So I want you to look at this clip. It's the sagittal image of the baby's brain, which shows you what happens in spina bifida, where the midbrain and the brainstem get displaced posteriorly and inferiorly. This is an axial section through the brain showing you a baby with a normal brain, and then it gets shifted posteriorly and the aqueduct disappears. If you just imprint those 2 images or record it on your phone, what happens in a normal and an abnormal baby, then you know what to look for when you go to work tomorrow morning. Because it's a very straightforward sign on sagittal axis. These are the other signs. Parallel cerebral peduncles, straightening of the mesencephalon, reduced BPD, reduced HCAC ratio, BPD in combination with serum amyloids, AFP, a reduction in the frontal maxillary facial angle, rotation of the third and fourth lateral ventricles, a dry brain, 4 lines versus 3 lines, the area of the choroid. It goes on and on and on. So many signs. Just go to work tomorrow and do 4 segments. First section, midline fats, lateral ventricles, plenty of fluid. Next section, cavity vein interplasm, plenty of fluid in the lateral ventricles. Next, plenty of fluid in the aqueduct of Sylvius. A good distance, more than 2.5 millimeters, from the aqueduct of Sylvius to the occipital bone. Plenty of fluid in the fourth ventricle, lined by a normal looking choroid. 100% normal. A baby you go tomorrow, work tomorrow morning, you see that brainstem, the intracranial translucency, the cisterna magna, the nuchal translucency. And you notice this fluid filled space is the biggest. Number 3. This fluid filled space, the intracranial translucency, is the cerebral fourth ventricle. Number 2. This is the cisterna magna. Number 3. Decreasing order of size. You may say, Simon, I don't want to measure anything. I'm okay. Just look for black spaces, 3, 2, and 1. If you see 3 black spaces that side, I'm okay. You say, Simon, no, I want to measure. What should I measure? I'll say to you 2 things you should measure. 1, you should measure the IT. Because a reduced IT is a marker for spina bifida, but an increased IT is much more common. It's a marker for many problems. Trisomy 13, 18, tiny fibroidy, 25 cysts, standard walker malformation, microdeletions, microduplications. And a second measurement, if you want to be enthusiastic, is measure the brainstem to the occipital bone distance, because that is reduced in the spinal. Okay. You may take also, if you want to record this, because this shows what happens with using a diagram. We show the aqueduct of Sylvius in here. This here shows the mesencephalon, cerebral peduncles, and this shows the thalami. That whole space gets shifted and the aqueduct becomes tiny. Again, just showing the same clip again, posterior displacement. We first published this in 2011, and then in 2019, 8 years later, this group went and reported exactly the same finding which we had made 8 years earlier, in the exact same journal, and they gave it a sexy name. They called it the crash sign. Unfortunately, we did not give a sexy name to our title. So I have learned a lesson that if you want to get your work recognized, make sure to pay attention in giving a good name to the title of your work. Not only did we report the crash sign back in 2011, 8 years before the crash sign was published, we quantified across 200 pregnancies, we quantified the change in the aqueduct of Sylvius to the occipital bone, and looking what the mean and the 2 standard deviations were for all these groups of cardiac measurement. I suggest that you put this table on your wall at work while you are learning to recognize what the normal is. I say greater than 2.5 is simple, but if you want more precision, this table will help you. Okay, very quickly. Normal, normal fluid. Spina bifida, no fluid, no fluid, no fluid, no fluid. Dry brain. Normal brain, normal cavity vein interplasm. Spina bifida, no cavity vein interplasm. Normal aqueduct of Sylvius, normal size. Spina bifida, no aqueduct or tiny aqueduct. Normal aqueduct of Sylvius to occipital bone distance, reduced distance in baby spina bifida. Normal shape to the midbrain and brainstem. It looks like a tulip flower. parallelism of the cerebral peduncles, spina bifida. Lemon-shaped head, normal-shaped head, spina bifida. That happens at 14 weeks of gestation. Okay, now I'm going to put you to the test and ask you to tell me which case is abnormal. Is this normal or is this abnormal? Which case has got spina bifida? I will freeze on the frame, that's important. Yeah? There. Which baby has got spina bifida? A or B? Yeah. And you can see the parallelism of the cerebral peduncles. You can see the aqueduct is obliterated. You can see that the midbrain and brainstem sit right beside the occipital bone. You can see the nice normal shape, the midbrain and brainstem. You can see the nice aqueduct facilities, and you can see the occipital bone is a good distance. Good. I want to show you a 4-quadrant example. Which baby has got spina bifida? When you scan this baby, you see nice fluid in the fourth ventricle, in the lateral ventricle. Nice fluid in the lateral ventricle. Nice cave vein interpulsum. Nice aqueduct facilities. Nice fluid in the fourth ventricle. Look at this baby. No fluid in the lateral ventricle. No fluid in the lateral ventricle posterior. Dry brain. No cave vein interpulsum. Absent. No fluid in the aqueduct facilities. Juxtaposed occipital bone. No fourth ventricle. So you see, on all 4 sections, you can detect the features of spina bifida by dividing it and why it's so important. Spina bifida. Spina bifida. Spina bifida. Spina bifida. Spina bifida. Spina bifida. 12 cases of spina bifida, which everybody in this room, when you go to work tomorrow morning, is going to recognize these because you see that the BPD is abnormal. And when you see the BPD is abnormal, you are then going to do a 4-section analysis of the brain. Another 12 cases. Spina bifida, spina bifida, spina bifida. All of these babies, there's no fourth ventricle visible. There's no lateral ventricle in some of them. Lemon-shaped head. Absent fourth ventricle. The brain shift. The brain shift. Which baby has got spina bifida? The baby on the left or the baby on the right? They both have spina bifida. Now the reason I show you this is because I think that's difficult to appreciate. I can appreciate it's got spina bifida because I've been scanning for 30 years. Because I can see that the brain stem is wide. I can see that the distance between the brain stem and occipital bone is reduced. I can see that the size of the intracranial translucency is tiny. That's the intracranial translucency, that's the cisterna magna, and this is the brain stem. I can see that the sizes of these fluid-filled spaces is abnormal. But that's taken years of training for me to recognize that. I can also see that when I look at the junction between the thalmi and the mesencephalon, which looks like a baby's bottom, when I look at that, it's pushed posteriorly and inferiorly. And how do I know? Well, this is the sphenoid bone, and this is the maxilla. If I draw from the tip of the maxilla over the sphenoid bone, that junction here lies below that line. It's called the maxillary occipital line. I don't draw the line, I just look at the tip of the maxilla, the sphenoid bone, and I look at where is the thalamus and cerebral peduncle in relation to it. But that to me is much easier to make a diagnosis. That to me is abnormal. But it will take some training for you to get to that point and recognize it. Okay. Another case. Also, you can see this baby, you can see the displacement, posterior and inferior, reference to the sphenoid bone. You don't have to measure. Look where it is. Look where the junction is. You can see it's abnormal. The axis section is very obvious. And then when you look at the image and you measure, start taking the measurements, you see, if you look at the point of the tip there, there's my sphenoid bone, there's the tip, and I'll draw a line over it. Sorry. I draw a line over the sphenoid. You see that junction lies below. Okay. I think just skip that. So next I want to move, remember looking at the spine. I said to you that 30% of babies with spinal bifida you would pick by looking directly at the spine. So remember, don't ignore the spine. But the spine can be extremely challenging. You say to me, Simon, this spine looks normal. I say to you, I agree. But the baby is the head sign of the spinal bifida. So what do? I said, well, look in 3 sections. Look at the coronal section of the spine. Now you can see the spine is exposed. Still, Simon, it's difficult. I cannot be 100% certain. Then I say, okay, well, try and get the baby to turn. So look at the time of the scan. That was at 14:16. I wait until the baby turns, and then I'm back at 13:56. I see here that there's an ulcer in the baby's skin. That is so difficult to appreciate. But this baby has got spinal bifida. This is a myelocele. So when you see the head signs, next move to 3D if you're finding it a difficult diagnosis. And in 3D you can now appreciate, as you go from segment to segment, that there's a spinal bifida. And then this is a surface rendered image from the same baby on both left and right screen. If you cannot be certain about the diagnosis of the myelocele, then bring the patient back at 15 weeks. Why 15 weeks? Because at 15 weeks, you will see the banana-shaped cerebellum. It's the sign of time of certainty that you'll be able to give an answer and a diagnosis. The third group is the spinal dysrhythmism, which is a grossly disrupted and disorganized spine. These are typical of trisomy 18 and trisomy 13. And the last group is closed spinal bifida. This is a patient I saw a few weeks ago. I looked at the brainstem, it looked okay, looked at the fourth ventricle, and it's the sternum angle looked normal. But when I went to look at the baby's spine, I could see that there was a defect as part of routine evaluation of the spine. Brainstem fine, IT okay, sternum angle, 3, 2, 1, okay. But looking at the spine, it had a lesion. This is a baby with closed spinal bifida. So we offer genetic testing. Genetic testing confirmed normal chromosomes, and she's now 20 weeks of gestation and continuing the pregnancy, counseled by a pediatric neurosurgeon and of a favourable prognosis. Sometimes these can be difficult because if they leak fluid, then they can be problematic later in pregnancy, like this one, which is normal head signs, closed lesion over the base of the spine. You can see the skin. There's no meningomyelocele, but it's over a large segment of spine. The risk is that there may be no head signs when she's present at 30 weeks, but this may evolve as the pregnancy progresses. Okay, finishing up, differential diagnosis. This is a baby with a mass at the base of the spine, the sacrococcygeal teratoma. I don't think it is a hard differential diagnosis because you can pick up this solid cystic lesion in most babies. This one, though, is more difficult. You'd think this looks like spinal bifida. The sonographer knocks on my door and says, Simon, I want you to look. I think this baby's got spinal bifida. I look at it and I say, I'm not sure it's got spinal bifida. Why? Because when I look at the gender of the baby, I always look at the level of the pubic symphysis, and I come down to looking at the gender. So I look here at the point where I see this baby's female. I see the female genitalia, and then I see the pubic symphysis. Then I look directly posterior to that, and I find the lesion is well below. That's the first thing. Then the second thing is I look at the sacral bone, and I see this is coming off below the level of where the sacrum ends. It's coming off the very tip of the sacrum. It's in a very low position. So then I look at my BPD, and I look at the thalamus. I look at the lateral ventricles, normal fluid, normal choroids, normal cavity, normal aqueduct, or smallish aqueduct, normal fluid in the fourth ventricle. And when I bring the same patient back at 20 weeks of gestation, normal posterior cranial fossa, no banana cerebellum, good lipophilic synthesis, drop the point posterior, the lesion below, female genitalia, and this baby's got a sacral constitutive teratoma. So be careful about making a diagnosis when you see a very low, what you think is a spinal defect. In summary, remember in going to work to routinely look at the position of the aqueduct facilis to occipital bone. Remember to look at the 3 black spaces, and remember to do a 4-quadrant analysis of the fetal brain. And in doing so, you'll be closer to making a diagnosis of spinal defect. Thank you for your attention.